Okay, so thank you, Deepa and Mike. I think you've all got a good introduction from Deepa and Mike on the channel disorders and what they are. And in the next sort of few minutes, I will try and focus on the children who I look after along with Deepa in the pediatric service. The service has been running for about 3 years now. Previously, they were seen at Great Ormond Street Hospital, but they were not in a dedicated muscle channel service. So some of you may be parents of children who are affected with these conditions. So you've already had a very good background about how rare this is and how the channel genes are mutated, and the symptoms include either stiffness or paralysis, which is often triggered by the activities mentioned before. And in children, if you look at it, there have been various descriptions for the last century, if you like, and every time a new type of presentation has been described. So we've heard about paramyotonia, myotonia, pediatric paralysis, Anderson-Tawil, but there are also other conditions like congenital myopathies with the channel disorders, where the muscle is abnormal, and also the risk of rhabdomyolysis, which has also been described with the calcium channel disorders. And very recently, there's been some work done where there's been difficulties with breathing, and I'll show you a little bit more on that as we go along. This is particularly relevant to the newborns and the infants who are just born, who may be affected with a sodium channel mutation. So you've heard that channel disorders can be due to stiffness or weakness, and we have the sodium channel, which can cause the paramyotonia, which some of you may have, also the periodic paralysis, weakness. And the same gene can cause the different types of presentations. And we work very closely with Deepa and Richa and Mike to figure out, which type of mutation it is and which type of symptoms that the person or the child is likely to get. And obviously the KCNJ2 for the Anderson-Tawils. So these are the various genes and the various descriptions. I'm going to swiftly move on to the children in our service. So this is the numbers grown since we last looked at our cohort systematically. So we have around 50 children now. This we did almost 1.5 years ago. And at the time, we had 20 children who were affected with myotonia, whether it was a paramyotonia or sodium channel myotonia, and another 10 with myotonia congenita, the chloride channel one. So you can see that, the stiffness symptoms are far more common compared to the symptoms of weakness and the attacks of paralysis. These children just add up to about 7 to 9 children here, and the stiffness symptoms are far more common. And how do the children present? So if you have children, or if you are a parent of somebody who's known to be affected, you probably may have seen symptoms like, when they wash their hands in cold water, the fists get clenched, particularly with other activities such as writing. They can struggle because they get writing cramps. Sometimes in the cold weather, if they sneeze, the eyelids might get stuck. And if they're infants, when they're upset and when they cry, you might see the eyelids getting stuck. We've recently noticed that squint is quite a frequent symptom, particularly in children with paramyotonia congenita, and quite a significant number of the children are under the ophthalmology service in our hospital. And you can see the presentation age groups. Majority tend to present under 5 years. And then some present a little bit later, the second peak being in the teenage, when they start to recognize what's happening and they can describe the symptoms a lot more clearly. In fact, last week, we saw somebody who has been struggling with this for, since early childhood, but hasn't been able to eloquently describe the symptoms. And that, led to a significant delay because it's the first case in the family, and therefore there was not experience before to recognize the symptoms. Some infants can have difficulties with swallowing, particularly when they're exposed to cold weather. So just like, you all who may have symptoms triggered based on activity, exertion, cold weather, children and infants are the same, but they just may present in a slightly different way, depending on what is the activity they do. They may have feeding difficulties because, in infancy, the main activity they do is feeding or crying, and that may be the main presentation. When they're older, they may present with leg cramps. They may have double vision if they have squint and eye symptoms, or they may be frequently falling over during physical activity at school, or may have muscle cramps. So these are the most common symptoms reported in children. But the reason for referral to our service is often this, and A lot of you may have children who are also in our service. So parents often are affected, particularly with the dominant ones, and then they quickly recognize the children have similar symptoms, and then they get Deepa kindly refers them to us. But as I highlighted before, there are substantial delays in diagnosis depending on, so if you have somebody which we can recognize, it's quite quick, but sometimes it can take, decades to get to the diagnosis itself. And when we looked at the periodic paralysis cases, again, 5 of them had family histories. So who knows how many there are which are not yet recognized. But when we looked at them, they all present with, episodes of weakness, floppiness, where they can't walk, and they feel like jelly-like. And the triggers are similar, like exertion, changes in temperature, carbohydrate meals like pizza. So these are individual children who we are asked what were the specific triggers or cold weather, and these were their genes which were affected. And in the periodic paralysis, most of the times it's the weakness that they had mainly, but sometimes there's a little bit of myotonia. And I just mentioned a little bit about this calcium channel mutation causing reaction to anesthetics. I always tell the children and their parents about, being wary of any surgery that they may have for the reaction to anesthetics. And I wanted to show you, the importance of recognizing this in infancy. So if an infant is born, so for example, if any of you are of childbearing age and have a baby with the SCN4A mutation, there is this difficulty where they can have this muscle hypertrophy, but the main problem is the stridor and the breathing. And this responds very well to treatment. And recently this was also reported, as a quite common frequency with the SCN4A mutation because of the breathing difficulties. There may be a strong association between the SCN4A. So I think it's very important that if you have children, just look out for these symptoms and tell your clinician. And we always warn the young 16-year-olds of the same risk, and I'm sure Deepa does as well in the adult service. So what we suggest is that in terms of treatment, I think Deepa has already highlighted the top tips about diet, lifestyle modifications, and for acute episodes, try to abort the attacks by moving gently if you can. And then for the respiratory and bulbar difficulty that I just showed you, we always refer them to the specialists for monitoring. But a large focus of the pediatric service is on educational support and school attendance, because for children, that's obviously extremely important. And later on in the session, my colleague Sian, who's also here, will highlight how we can support the children during the school periods. In terms of medications, Deepa's already highlighted, we use similar drugs, although I think we're a little bit more conservative in the sense that there's not a lot of evidence, and a lot of studies and research is quite difficult to do in children. So we often go for mexiletine, which is thought to be the safest. But sometimes in infants, we may use carbamazepine, and more recently we've started using what we called lamotrigine. And that was for the stiffness symptoms. For the periodic paralysis, the drugs are again similar. So our first preference is, acetazolamide or potassium supplementation. And then occasionally I have used amiloride, but I have not used the other two, which can be difficult to get in the children. We don't prefer spironolactone because of the side effects for gynecomastia. So some of the drugs we try to avoid, but most often we use either potassium or acetazolamide. And when we looked at our own, cohort of children, not everybody needed to be on treatment. So out of the 38, only 29 were on treatment, and 16 were using it for the non-dystrophic myotonias. And for the periodic paralysis, 7 of them were on the acetazolamide, and they all were responding quite well to mexiletine. They were quite satisfied with the response. There were no cardiac side effects in the children. There was just one child who had metallic taste and some abdominal pain and headaches, which resolved soon after. And like all of you, we also advise them to take it with meals. And in terms of the support, extra support was required in school for most of the children, and school attendance was a big problem. And also for children, sometimes we advise them to take it only in the winter. Some symptoms are worse in winter. And in others, they may take it throughout the year, depending on their physical activity level and the lifestyle. And acetazolamide, we've had 2 children where we've used in one child, but it hasn't worked for that particular child. So I'll just hand over to Sian before I summarize. Sian, are you on the line? So I can run the slides for you if you can.
Thank you. So I'm Sian. I'm one of the children's CNSs that works at Great Ormond Street. I currently cover the Channelopathy service, but I work with 2 other CNSs and we all cross cover. I am essentially your link to the channel service. So if you would like to, if you have questions after your appointment, often we give quite a lot of information in one session. Sometimes it's nice to just drop me a message and we can have a little chat about everything that we've talked about in your clinic appointment. If you need some written information provided, either for yourself or for schools, clubs, sometimes for family, sometimes it's nice to have something written that you can go through with family members. If your child's struggling with some symptoms, we can make an appointment. We can go through things like diet, triggers, exercise. It might be that we've suggested that you do a food diary or a trigger diary. So we can go through that. Things like treatment options. So in our clinic appointment, doctor might have given you a few options about medications. We can go through those as many times as you need to, go through side effects, go through what might work best for you guys, any monitoring that's linked to those. Again, if we do telephone appointments, so I run telephone clinics every week. I generally run them on a Thursday morning, but we can be really flexible, especially if you'd like your child to be there, especially if they're older. We can do appointments after school, so we can chat with them, see what they think, how they feel. Next slide, is that all right? Yeah, the other big thing that we do is contacting other agencies. So things like schools, clubs, going into college, making sure that they have a good understanding of your child's condition. The big thing is making sure they know that every child is different and that every day is different. And that can be quite difficult for schools and things to understand. So we can be a big part of that. We can provide some written information. So we do letters with lots of advice and guidance for them. We also encourage them to contact us. So we can be part of, usually we like to arrange like a Zoom call with teachers and the family. And that way we can talk openly with school about parents' concerns, what they're struggling with at school, what school are struggling, what they can provide, what they should provide. The other thing is actually we can refer to other services. So actually, if you need some more support, whether it's access to our family therapists, or you need some practical support with finances or housing, we can refer to our social services department as well. So we have lots of lovely information leaflets. So they are all available on our website. Please feel free to download. If you can't find what you're looking for, please just contact me. We can have a little look. I can email things out. And we also have alert cards. So when we do your diagnosis appointment, we'll often give you an alert card just to keep with you. If you'd like one, please contact us. We can send them out. Or if you need more of them. So as Dr Munot said, the big thing that we do is school support. So some of the most common things that we recommend are, if your child's struggling with stiffness in the hands and prolonged periods of writing, it might be provision of a laptop, if that works for them, or actually getting them to work with a scribe or dictation software. All kind of depends on individual child and how old they are. Really making sure that school understand things about triggers. So things like not sending your child out with shorts and t-shirt in winter, just really not going to be very helpful for the rest of the day. What kind of modifications can they make so that your child can have full access to the curriculum? And that is the big thing. Sometimes if the modifications aren't enough, they need to apply for an EHCP, and we can support with that. If we need to be part of appeals and mediation for that, quite happy to be on videos and explain things. It's also really useful when you're transitioning to secondary school. And we can make sure that we can have a meeting with your current school, secondary school, to make sure that everybody is aware and that proper things are in place to make sure that everything goes smooth.
Thank you, Sian. I'll just summarize Just for children, I mean, the main challenges we've had in our service are the availability of mexilatine, because a lot of the family practices as well as the pediatricians sometimes struggle because it's not licensed in children. And it's not because of the safety concern that it's not licensed, it's just that there haven't been studies in children to assess the efficacy and the safety. But as you've seen from our data, it's relatively safe and well tolerated. The other challenge is obviously delay in diagnosis, which frustrates many family members and children because it takes years to get to the bottom of the problem. Periodic paralysis can be very difficult because, sometimes, as I said, as Sian said, schools can struggle to understand how on some days children can be so well and on other days not so well. So that's a particular concept which is very difficult to explain to the school members. And sometimes, the possibility of increased weakness as they get adults, but that's not so common. And then the other thing is sometimes we find mutations which are not clearly resolved, and therefore we need to work closely with the lab to figure out if that's actually causing the problem. So these are the main difficulties that we face in the pediatric service. So summarize, in children, it's the same symptoms, myotonia and stiffness, but it just depends on what is the age of the child and what activities they do that will impact the presentation. There are many different presentations and genes involved. There are lots of delays in diagnosis. So if you are concerned about your child having this kind of condition, we take referrals from GPs, pediatricians, or even self-referral. We can then track your GP down to send us a little note to say, can you see? And then just, we make sure we educate as much as possible to all specialists who look after children to examine for myotonia when children presents with motor difficulties or physical difficulties to any of them. And recommend testing for muscle channel disorders in children who have these kind of variable fluctuating symptoms, and lots of treatment options. So we work closely, as we said, with Mike, Deepa and the lab colleagues to help the children. So just finally to acknowledge all the colleagues from the lab as well as the Kosh clinical team and all of you to allow us to have this data and share it with you. So I'll just stop.